opioid burns. Modest, while we were fighting some devils and battles, I guess I better say, over at the connector, you had your own battles around reforming the auto insurance industries, auto insurance regulations that we call. I'm sure you and Michael had some discussions about that as well.
Oh, we did.
Okay, I took my instructions from Jennifer Nash, who gave me 3 questions, but I think given the 10 to 15 minutes, I'll just focus on the first one, which is really why, when might it be appropriate, thinking about the connector, to think about government intervention. And it's a very apropos question given the rise of the Tea Party, which as far as I can see, if they have a philosophy that's galvanizing people, it is anti-government, it is less government. As little intervention as possible. So it's definitely topical. Maybe I misconstrue that. That's my small read of it. So let me start. If you have this little thing in front of you, I'm going to start on slide 2 and just give you a very brief sense of what an insurance exchange does. It was actually originally called an exchange by Romney, and then the legislature decided that was too commercial. And so they renamed it a connector. In fact, under the Affordable Care Act, which those of us who are painfully steeped in the details of it lovingly call the ACA, so that's what they're slipping into. Under the federal reform, the ACA, there's actually a huge function in just determining eligibility for subsidies. This actually is a sort of a revolution going on in the way people qualify for means-tested programs, health programs in the United States under this law. Not entirely clear that it'll work or how it'll work, but we're now going to be like much of Europe using annual income tax filings as opposed to two-pay stubs and a bunch of mushy stuff to try to figure out whether somebody qualifies for subsidized insurance. So we just delegated that to Medicaid and kind of piggybacked on their process at the connector, but nationally, huge effort going into determining eligibility for Medicaid, children's health insurance programs, and these new tax credits for the exchange. Beyond that, and that's like half of what these new exchanges are going to do, is specifying what health insurance plans are going to be offered, and particularly what kind of cost-sharing formula are going to be available. Selecting and contracting with those private health plans, these are private health plans, and marketing them. Insurance is what we call a grudge buy. Nobody wants to go down to their corner insurance company or broker's office on a Saturday morning, smell the new leather, and test run this baby and see how far you can get up from 0 to 60,000 miles of coverage, $60,000 of coverage in nanoseconds or a few seconds. It's not like buying a car. People don't like it. They don't want to think about it. They hate it. If there's any way they can avoid things about it, they will. So marketing is no small task. Helping consumers actually make intelligent choices about what can be a $5,000 to $15,000 a year annual expenditure that they don't understand, don't want to ever use, and if you've ever tried to read through an evidence of coverage, you have a lot of sympathy for it. And then a whole bunch of sort of public education and outreach because people are anxious, they don't know what to do. We held 338 meetings across the state in the first 2 years with business groups and religious groups and community groups, just explaining what this health reform thing was. So that's kind of what a connect or an exchange does. Why? Why do that publicly? And I'm going to frame this question by informing you, if you're not aware, there are private exchanges. There are electronic exchanges out there for health insurance. E-health insurance is one, Get Insurance is another. And you can go on their websites and they have all the technology. In fact, they have some better technology than we were able to use because of a political restriction that we shall use a domestic firm as our sub-connector. That's cutting out 98% of the rest of the country as a source for technology. That's one of the downsides when you get into government. Good for keeping jobs in Massachusetts, but not real good for serving customers. So anyway, there are these private exchanges. Yeah, I told you I'm going to be in the middle between. There are these private exchanges. Why do it publicly? One, obviously, is to subsidize the poor. And if you look down the bottom of the page, you see Jacqueline. And this is a classic and age-old debate, whether or not to subsidize the poor for basic necessities. Is healthcare a basic necessity, a right versus something else, et cetera, et cetera. But Jacqueline's a nice illustration on both sides. Jacqueline is a high school teacher a public school teacher in Norwood who had insurance after she graduated and went to work there. And then she, and I'm not sure why, left that job and went to work in her family restaurant. And like any very typical of a small establishment like that, they didn't have health insurance. And then she had a lump in her breast. And actually her PCP told her it was okay, it was fine, but she had doubts. She didn't see a specialist until she qualified for Commonwealth Care, which is the subsidized program. And turned out it was malignant. And you know, one or two things would have happened. I mean, you can fill in the rest of the blank. She's alive and well and happy and the spokesperson for the connector. Because either she would have put off the appointments and died, or her parents would have lost their house or the restaurant paying the $100,000 bill to take care of her malignancy. So that's sort of the case for it. On the other hand, you know, Jacqueline's the daughter of middle-class people, and there are legitimate questions about how high up are we going to subsidize people for health insurance. 400% is the federal poverty, which is $88,000 for a family of four, is the top of the scale under ACA. That's above the median income in a whole lot of states in this country. So, you know, there's some questions about this. Anyway, that's one thing that you can't delegate that to a private entity to do that means testing and subsidization. I mean, you could have some customer service folks do it, but they have to be carefully overseen. It has to be a public function. But what I want to engage you on is the second issue, which is correcting market failures. And for that one, I would turn to page 5 and 6, or slides 5 and 6. And I come out of 25 years in the, albeit nonprofit, in the health insurance industry, so I feel fully qualified to criticize health insurance. And I should preface this by saying most of the ones I know are actually good people. A lot of them are Democrats.
Most of them are.
Most of them. And they're responding to the incentives in the system. And the incentives are pretty clearly that the underlying health status of the insured population determines your cost. So if you want to compete, the easiest, simplest, by far most significant way to compete on cost is to insure a disproportionately large share of people who don't need insurance for health. It is also so this is one of the big market flaws. There's intense competition in insurance, health insurance, but it tends to be what I would call socially unproductive in the sense that it's about screening. Here in Massachusetts, for like I said, our well goes back not far. I'm thinking not as far as the 1850s, but in the 1990s we had community rating for the particularly most selective, most flawed part of the market, individuals buying on their own. And so guaranteed issue and guaranteed renewal.
Tell folks what that means.
I'm going to explain. So that means that you can't be, if an insurer offers a product and you as an individual household want to buy it, they have to sell it to you. The next year when you go to renew it, they have to renew it. And the price they can charge you is constrained. Under what we call adjusted community rating, it can have some variation for age, which is a predictor of expense, but it can't vary by your health status. Okay? So you can be sick as a dog, and you can get insurance, and the price is constrained. You know, it can't be more than like twice as much for a young, healthy person. And health isn't even a rating there. And they have to issue to you, and they have to remove it. So you can easily imagine, since most people know what they're predicted relatively well, how much, other than for non-anticipated emergencies, what next year's costs are going to be. You know, you've got multiple chronic conditions, you're on a lot of drugs, you know you're going to be expensive. You're the one who goes and buys that guaranteed issue plan. Or you wait until you get sick, and then you buy it because you know you can always get it. So sort of like the analogy is, it's like letting people buy homeowners when their house is on fire. So the carriers have various ways of sort of protecting themselves against that. Medical underwriting, we outlawed that in the 90s. The result was we had very few people who were very sick who could afford to buy this insurance, and the insurance was very expensive. So that's where this mandate comes in, saying the young, so-called young invincibles, the rest of the population, they also have to participate. So that's all this thing about risk selection. The other flaw is it's very hard to decipher. And frankly, if you look at the people who are out there, the experts helping you to decipher insurance, brokers, with all due respect, I love brokers. They are actually called agents. They are agents of the carriers. They are paid by them. And in the non-group market, they're really not even available. And then you have all these sort of infinitesimal, there's too many S's, and infinitely variable products that are very hard to decipher. And I did product development. I was very proud of what products we developed, but I can tell you there's a lot that goes on to mask the ability of the consumer to do an apples-to-apples comparison. So one of the problems with these private exchanges is they are like brokers, agents. They are paid by the carriers. Okay? So they are agents of the carriers. They have no ability to sort of mandate, give us only your highest value products. We want standardized products that we can compare. We want to simplify this. Now they have technological solutions that they introduce to try to cut through some of the clutter, but basically they're bound by the carriers, and of course they operate in most states without guaranteed issue or renewal. So, for example, when Abby, who's an upper middle class self-employed business person, consultant like me, moved to Massachusetts from an unnamed liberal progressive state on the east seaboard, just above Washington D.C. and below Delaware. She was told that she had multiple chronic conditions, so she would not be able to get insurance when she left Maryland and left her state. And was delighted when she moved to the Berkshires to find not only could she get it, sort of reasonably priced, but she could get on the connector and give us 3 pieces of information. The zip code, because that's a rating factor, and also not all plans are available on zip code. Her household size, and her age, because age is a rating factor. And did she want sort of gold or silver or bronze level coverage? Higher premiums, less cost sharing when you see the doctor. Lower premiums, bronze level, and more cost sharing. And so she did that, and could make an intelligent apples-to-apples comparison, make a $10,000 purchase, all in about 20 minutes, push a button, she's automatic, she's enrolled, and she's paid her first month's premium. The contrast between that and the traditional shopping experience for individuals is enormous. Before the connector, she moved here, even with guaranteed issue and renewal, community rating. She would have called Blue Cross, she'd wait 10 minutes, you get through to a customer service rep, what have you got? Well, we got seven products, well, which one's for me? Well, I don't know, what do you want? Back and forth, and about half hour later, she'd have scribbled 2 pages of notes, and then she could call Harvard Pilgrim and do the same thing. And at the end of the day, she'd have 20 pages of notes, she was really assiduous, and she'd walk across the street and ask her neighbor what she wanted. And that's kind of the shopping experience. That's the empowered consumer without this kind of intervention. So that's why I think a public exchange has some value. I'm going to try to wrap up with this. So if you look at slide 7, I already talked about the community rating, so that the guaranteed issue and renewal with the mandate, so that basically the health insurance market works for the sick as well as the healthy. Transparency and trust could be commercialized, but the standardization of products, and I have to tell you, again, I mentioned I do product development. I was really enamored of let 100 or 1,000 flowers bloom philosophy. When we started off, we said to the carriers, you give us what you have or you want us to sell on bronze or on the silver level, on this gold. And they're sort of equivalent, what's called actuarial equivalent. They're sort of basic same value, but one might have a $2,000 deductible and no cost sharing when you see the doctor, and the other one might have you pay 35% of the bill when you see the doctor, but there's no sort of upfront responsibility or deductible. And and then we had huge price differences. So they were all the same value, if you will, on this bronze or silver or gold tier, but big differences in benefits and big differences in premiums. And so the consumers thought, oh, well, that one's 30% cheaper. That must be lower, cheaper benefits. Why else would it be less expensive? So we have traditional, conventional consumer shopping economics doing just the opposite of what we want it to do, in motivating people to buy the same value at a higher price because they think they identify price with quality, because it's very hard to understand and measure. So over time, we actually responding to consumer requests. We standardized the cost sharing of the product so they could do an apples-to-apples comparison. And the result is that a very high proportion, disproportionately high proportion of our consumers in this is the unsubsidized Commonwealth Choice Program, with about 40,000 people now, buy what I call no-name generic insurance plans with limited networks, very small overhead, 6, 7, 8% overhead, and 20, 25, 30% lower premiums than the better advertised, much more administratively encumbered and expensive broad network health plans. And this is seen as something that fits them as consumers, these are voluntary choices, and can drive some creation of value and some pressure on healthcare costs. The results quickly, very high public satisfaction, there's steady enrollment growth. We're up 10,000 enrollees just since I left, which probably has a lot to do with it.
Somebody ought to go.
40,000 in this unsubsidized, and about 160,000 in the subsidized next year, so 200,000. But I would say, the thing I told you about driving consumers towards the lower price plans, I think does enhance price competition. There's some negative consequences of all this, but sort of the two biggest, and I'm going to switch sides, problems I see are, despite great need and expectations for cost containment, this is really not fundamentally changing the healthcare economics dynamics across 6 million insured in Massachusetts, or 4 million privately insured, 2 million publicly insured. And so it hasn't had much impact on cost, one way or the other. And there's also significant opportunity for politicization. So now the governor and the nominee successor are regulating health insurance premiums. And when the connector talks in partnership with the vendors, Connector is a retail store. It is an exchange. I used to remind the board, some of them would grimace when I said it, we're in the business of hawking insurance. That's our mission. We're trying to enroll people. And so you have to work with the carriers, who are their store, in a sense. They are your manufacturer. And now we have the governor and the Consumer Insurance regulating their rates, and that creates this very strange dynamic between the retailer and the manufacturer. So, I don't want to get into why that is, but let's say we enjoyed benign neglect until election season. We'll just leave it at that. So I'm going to stop there because there's some other issues that Jennifer wanted me to talk about. I think I've way exhausted my time.
It's okay.
And for most people.
And let's get into this. By the way, just a reminder here in terms of the role of